Thank you very much, Dr. Hassan, for this nice, clear presentation regarding the laser treatment, stone treatment by laser. Before starting with the second topic, I would like to express my deep thanks for the organizing committee to give us this chance to meet with our international guests and to change the experiences. I believe in Kuwait because for the low volume of patients, as Dr. Khailaoudi said, such conferences with practical and theoretical sessions will be very necessary for our newcomers, urologists in future. Again, thank you very much for the organizing committee for having this chance to meet with our guest. Now, the second topic is how I do management of stones in ectopic horseshoe kidneys by Dr. Wissam Kamal. He is the president of lithotripsy steering committee in Saudi Arabia. I hope that, are you ready, Doctor? You are ready? Are you ready? Okay, you have 20 minutes.
Okay, first of all, thank you for the kind invitation. So today we're going to speak about urolithiasis in horseshoe kidney and ectopic kidneys. So horseshoe kidneys, just a brief, is a common congenital malformation. It's the most common fusion anomaly occurring in 1 to 600 births. It's characterized by the fusion of the kidney at the lower pole with the consequent failure to ascend and malrotation of the kidney. The high insertion and the lateralization of the ureter causes drainage deficit and leads to increasing the chance of stones, which happens in 35% of the cases. An important anatomical features that we see in the horseshoe kidneys, they are usually lower in the abdomen, they have a high insertion of the ureter, the renal pelvis is abnormally oriented, and there's abnormal vasculature. They have multiple small vasculatures going mainly to the lower pole. But not all the time that we have the kidney is lower in the abdomen. Actually, in 40%, the isthmus is exactly in its place, and in another 40%, the isthmus is lower in the abdomen, and in 20%, it's in the pelvis. So why is stone in horseshoe kidney special than the other stones? The treatment of stones in horseshoe kidney in the European and the American guidelines, they do not have a specific treatment or specific guidelines for that. However, there are special anatomical features that might alter the decision. Stasis, due to the abnormal drainage, is the most common cause of increasing the stone, and hence, the urologist should be alerted to try the procedure with the highest stone-free rate, targeting to complete stone clearance, as even small fragments may not pass because of the deficit of the drainage. So, what's the problem in ESWL? As we mentioned, horseshoe kidney are commonly lower in the abdomen, so this might make the ESWL targeting more difficult. In the way we can find the bony pelvis, the transverse process of the spine, and the vertebral bodies. In these cases, ESWL might be done in the prone position to get successful. So, as we can see here, the outcomes of ESWL in horseshoe kidneys, the initial stone-free rate are very low, ranging from 22 to 50% at the maximum. It could reach up to 100 in second procedures. Another problem for managing stones in horseshoe kidney with flexible ureteroscopy is the high insertion of the ureter. Imagine if the insertion of the ureter is this high and the stone is here. How can you reach the stone with the flexible ureteroscopy? You have a strong degree of deflection and a long way to traverse down to the stone. However, flexible ureteroscopy has better results than ESWL in horseshoe kidneys. This is a system, and it ranges from 55 up to 100% in some cases. This is a systematic review and meta-analysis comparing ESWL with flexible ureteroscopy. Of course, as we mentioned, flexible ureteroscopy has higher stone-free rate, but both have the same retreatment rate. the unique anatomy that the renal pelvis and the ureter are anteriorly, and I think this is an advantage for laparoscopists because it's easier to perform pyelolithotomy and pyeloplasty in such a cases. So what about PCNL? The stone-free rate of PCNL ranges from 81 to 87%, which mimics the stone-free rate in the normal kidneys. The risk of major bleeding vessels is also not higher than the normal kidney. The puncture, if we ask any urologist, he will say the puncture of the horseshoe kidney, the puncture should be made below the throat rib, posterior line, coded angle of the puncture, and you should make your puncture in the upper pole. Why is that? Because the kidney lies down. You can see here on the left side the horseshoe kidney, and on the right side the irregular kidney. If you can easily do an upper puncture or upper pole puncture in the horseshoe kidney, the pleura is far away. You don't have a risk of injuring the pleura. While if you want to do a puncture in the regular kidney, you can easily actually puncture the pleura. But even though you have a good access to the upper pole, what you notice during PCNL and horseshoe kidney is that you have a long way to reach the entire kidney. So most recommend that, especially when you do perform PCNL in horseshoe kidney, that you use either longer nephrostomes than the usual, or you use a flexible nephroscope to be able to reach all the calyces. So this is the bullseye technique in the days when I had my fellowship with Prof. Lyatsikis. As you all know, that he does the non-calyceal puncture. He punctured the upper pole directly with the 30-degree bullseye technique. And just as the usual PCNL, he did the implant's dilation. So as we mentioned, usually it is said that PCNL and horseshoe kidney should be done in prone position because the kidneys lies medially, and maybe there's a long way in supine PCNL to reach the kidney. And here, Fabio Vicente from Brazil analyzed 160 procedures in a multicentric for horseshoe kidney, and he found that 63% did the PCNL in prone position, and 37% they did it in supine position. There was no significant difference in transfusion, complication rate, and initial stone-free rate between the two groups. Surgical time was significantly longer in the prone position. Upper pole was preferred in axis in 80% in the prone position, while in supine position they actually prefer the lower pole more than the upper pole. This is the way I do it. This is, I put the patient supine and just elevate the patient 15 degrees. This is one case. You can see he has bilateral stones more on the left side, and he has just tiny fragments which are actually from stages in the horseshoe kidney. And this is the CT of the patient. You can see multiple small stones on the left side. So this is the RGP image. If you can take a look at the second picture, especially if you see the upper calyx, imagine that we did our puncture calyceal through the upper calyx. We could only reach the upper calyx. We cannot reach the rest of the kidney with the rigid nephroscope using the upper calyx. So this case was done in supine position. We could reach all the calyces, and the stone in the upper calyx, we reached it with the flexible nephroscope. And here, because of the position of the sheet itself, it's going like parallel or downward. All of these fragments, we didn't even fragment it. The tiny fragments, it's just washed out with the Venturi effect. While we're putting the nephroscope, all these fragments were coming out. And the stone in the upper calyx, we fragmented with the laser with flexible nephroscope. You can see here the flexible nephroscope going to the upper calyx, and this patient was cleared in one session. So if we want to compare the puncture, the degree between the normal kidney and the horseshoe kidney in prone position and supine position. We found the first one with the 30 degree in prone, and the other one in the horseshoe kidney, it's a little bit medial, while the same patient, if I just tilted the picture 15 degree to make the puncture parallel to the ground, you can see that we're going through a good parenchyma, and we can reach the pelvic system, and it's not actually longer than the other tracts. So another advantage of performing PCNA in a horseshoe kidney in supine position is the ability to perform endoscopic combined intrarenal surgery and simultaneous bilateral endoscopic surgery. So one might ask, why would I do endoscopic combined intrarenal surgery if I have a flexible nephrostope? Well, it was studied and found that doing a retrograde flexible ureteroscope can reach up to 94% of the cases, while doing an antegrade flexible nephrostope could only reach 74% of the cases. Simultaneous bilateral endoscopic surgery is another thing. This procedure was popularized by Guido Gusto et al., which is doing a PCNL on one side and flexible ureteroscopy on the other side simultaneously at the same time. This is the position we apply when we do simultaneous bilateral endoscopic surgery or endoscopic combined intrarenal surgery. This is also a case of horseshoe kidney which has bilateral stones. On the left side, we did a mini PCNL, and on the right side, we did flexible ureteroscopy, and the patient was stone-free in one session. So, why simultaneous bilateral endoscopic surgery? Actually, the question is why not? Historically, working on two renal units doubles your trouble. It increases the risk of bilateral obstruction, it increases the risk of pilovenous return, and hence the risk of UTI and sepsis. But what are the advantages? It can shorten your waiting list, decrease the need for multiple admission and its impact on the hospital and the patient, more operative time for the surgeon and the hospital. And here's a short video of us doing the simultaneous bilateral endoscopic surgery for that last patient. We used the mini perc in this case. The energy source was the Soltive TFL on the right side with the mini perc, and we used the holmium on the other side with the flexible ureteroscopy. So I want to show you this case. This is a sad story. This patient had also horseshoe kidney with this large stone. Her physician convinced her to do a stage ureteroscopy. She went for 3 sessions of ureteroscopy. Each one of them is around 1 hour and a half and 2 hours. By the end of the 3rd session, she was stone-free, but she came 2 months later with abdominal pain, and you feel a mass just beneath her skin. You do ultrasound, you find severe hydronephrosis. We took her to the OR just to find this long ureteral stricture, just because he didn't follow the guidelines and applied the stage ureteroscopy with the prolonged ureteral access sheath. So we'll move on with calculi ectopic kidney. It's a rare occurrence, happens in 1 to 3,000 births. What are the issues affecting stone management in these cases? The bowel surrounds the kidney, which can cause bowel injury. It lies on bones posteriorly. It has abnormal vasculature, which can lead to vascular injury. The renal pelvis faces anteriorly and medially, and we have abnormal orientation of the calyces, which also affects the drainage of the fragments. So, for irritable ill, there's difficult localization and impaired clearance. For URS, tortuous ureter leading to difficult access and impaired drainage. And for PCNL, it's technically difficult access. So here's a study about irritable ill and ectopic kidney. The success rate depends mainly on 2 factors: the stone size and the location of the kidney. In ectopic abdominal kidney, it can reach up to 100%, but in pelvic kidneys, it's almost 0. How to do PCNL in ectopic kidneys? It's either by ultrasound-guided access or laparoscopic-assisted access. This is a procedure which is described by Sabins et al. From India. He pushes the probe of the ultrasound down to the kidney, and by that he pushes the bowel around the kidney, and just when he sees nothing there between the kidney and the probe, he does the puncture. A lot of reports are describing the laparoscopic-assisted PCNL. Most of them are case reports because of the rarity of this disease. And because of the rarity of the diseases, sometimes you find you have to do personalized approach. For example, this is a procedure describing a transgluteal approach for a horseshoe kidney in the pelvis. Here's a case for us. This patient has a cross-fused ectopia. You can see that the stone is lateralized and the pelvis is facing anteriorly. We have to do angiogram in these cases just to check for the vasculature, where is it coming from and where it's going, not to be in the way of our puncture. You can see here in the lower pole, you can see the filling defect of the stone. The stone is almost 2 centimeters, and when you see the ureter, you can see why we didn't choose to do flexible ureteroscopy. It's very difficult to put an access sheet across that ureter, and the drainage of that system wouldn't be sufficient to evacuate all the fragments. So we did a PCNL there, and the patient was 100% stone-free rate, and we didn't even have to put an nephrostomy tube. This is the last case I want to show you. We didn't manage this case yet. So actually, this is the video is not working, unfortunately, but this is a pelvic kidney with multiple big stones. So initially, we wanted to evaluate the patient. We did an RGP and put a DG stent just to relieve her symptoms. During RGP, we found this. So another pathology is that she has a UPJ obstruction. So what do you think is the proper management for this patient? I referred her to a laparoscopy, but they said it would be difficult because of the renal pelvis. And then next week, she's going to do robotic pyeloplasty with the right ulcer, and he's going to go through one of the ports with flexible ureteroscopy to fragment that stone. So, what does the future hold? Dr. Hassan Rafzi was speaking about the two-lane fiber laser. As we mentioned, one of the biggest problems in the horseshoe kidney or ectopic kidney is the drainage of the fragment. So we always aim to clear the patient. But maybe with the TFL, we can produce this fine dust, and we don't need to go with the basketing, and we can go faster. And the decreasing the size of the ureteroscope could lead to decreasing the need of urethral access, a big urethral access sheet or urethral access sheet at all. And we can go with the prolonged procedure a little bit without fearing of injuring the ureter. And we also have urethral access sheets with suction, active suction with fragments and dust, and maintaining lower intrarenal pressure. So these advances in the urology might actually change the guidelines in the future. In conclusion, there is no consensus in which approach is the most appropriate for managing stones in horseshoe kidney or ectopic kidney. A tailored approach on patient-to-patient basis should be considered. Factors to be considered: patient factors, renal anatomy, vasculature, body mass index, hardness of the stone, size of the stone, coagulopathy and associated pathologies, surgeon's experience in the urology versus minimal invasive, and available instrument if you have a high-power laser or TFL or miniaturized PCNA. Thank you very much.